So very good afternoon to one and all who are all joined for the today's interesting learning session on Indian knee arthroplasty conclave presented by Shah Hospital in association with Corona Remedies. So we are very happy to have this session, host this today's session with Dr. Manish sir, and sir is known for his expertise in knee arthroplasty very specifically. And the journey of this knee arthroplasty conclave starts from today, and we are going to have fortnightly session, 15 days one, and we'll have a complete learning from the sir's expertise. And I welcome Dr. Manish sir to have the first session of today and take the journey of knee arthroplasty to every Indian orthopedician with his expertise. And just before handovering the session, I would like to introduce Dr. Manish sir. So Dr. Manish sir is currently a consultant at Shah Hospital, and also he is a honorary arthroplasty surgeon at SVP Hospital at Ahmedabad. And sir has been acquired many fellowships across the various prestigious institutes around the globe. And for his incredible contributions to the orthopedic specialty, he has also been recognized with various awards and recognition from the Ahmedabad Medical Association. And currently, sir is holding patent pending for his devices, which has been developed for a knee replacement as well as shoulder replacement. And sir has currently developed as a in his professional domain. So he has been developed various technologies, very specifically Artho 3D and Artho 3 Robo MR. And his passion for humanoid robotics is what made us to connect today and what made us to connect for a learning goal of ours in knee arthroplasty concern. And to achieve this goal, so we welcome Dr. Manish sir. And Manish sir, thank you for taking up this today's interesting session, sir, for us by sparing your time and in spite of the busy schedule. And no doubt the Indian orthopedics will definitely get benefit out of this interesting session, and they will be definitely one level above after the series in their knee replacement concern.
Is my screen visible?
Yes, sir. Perfect, sir. Good to go, sir.
Great. Thank you. Today we start off with the history part of total knee replacement. And it has a very long and interesting history. And unless we are able to see what was there in the past and how this has evolved, we are likely to repeat mistakes of the past. And that is why learning the past is very, very important. let us see this interesting journey from the 1970s to the present. As we uh, look at this, it's very important to understand a few basic caveats that the biomechanics of a total knee replacement are quite different from what we have in a natural knee. ACL is the first casualty of any TKR, and the shape of the poly and the shape of the femoral condyles definitely change from implant to implant and their designs. And that is why comparing the biomechanics of a TKR with that of a natural knee can be a challenge. It is very, very important to understand that these are two different animals. Similarly, changes in alignment, access, and constraints can also play a major role. And we hope to have a look at the history with reference to all of this. Like I said earlier, those who do not study history are doomed to repeat it. The evolution of TKR can essentially be classified in four different generations. The first generation from the 1970s to the mid 90s, then on to the second generation, the third generation leading up to the year 2000, and then the fourth generation. We will look at each of them in a little more detail. What do we aim to look for? We aim to look at the chronological review, look at the key names and brands, and identify the generations. The first knee was put more than 100 years ago by Gluck. And would you believe it, that this was ivory? Ivory is a ceramic. Chemically, ivory is a ceramic. So the first knee which was put in was a ceramic knee. In the 1890s. Then 1951, Waldius came up with the acrylic one. Cobalt chrome came around 1958. These were essentially hinge designs only. And because of that, they were associated with failures. Poor metallurgy, poor fixation, infection, overall poor function, and early failures. But something changed in the early 1960s. Polyethylene and UHMWPE was discovered in 1963. There was introduction of cement in 1960. And that solved the major problems of fixation and motion. And with that, there was an explosion of designs in the 1970s. The challenge was to create a non-hinged or an unhinged TKR, which would be stable, which would last long, and which would give a good function with a very good range of motion. The design features essentially developed along two distinct directions. The goals were the same. What were the goals? Stable, long survivorship, good range of motion. But the methods for achieving those goals were different. One was functional, wherein anatomy was sacrificed. They came up with simple engineering solutions, simplified mechanics, removal of ligaments, increased contact areas, and simple alignments. A mechanical alignment, constraint built into the system, removing the cruciates, and coming up with a functional solution which would last long, which would give a predictable result, and which would give a good range of motion. The other group which was working towards anatomical solutions, wherein they wanted to preserve tissues and they wanted to create designs which would reduce the conflict with the tissues. Thus, two distinct directions emerged. If we look at today's design, anatomical, we know that implants are now left-sided and right-sided. Functional, because quite often we remove the PCL and put a post. So overall and over time, both the functional designs and the anatomical designs merged. A left PS knee is a combination of both anatomic as well as a functional design. And hence, it's important to remember that in each design, what are the features which are there as a functional feature and what are the features which are anatomic, which are preserving the basic anatomy, reducing conflict with those tissues. As we dive deep into the generations, we hope to be able to distinguish the heritage from where the newer generations are coming in. The first generation from the 1970s and 80s up to the 1990s, there were many ideas and designs, both functional and anatomic. And what happened? The natural selection with the best designs. How? Surgeons who started using it, anything that lasted, that gave a reasonably functional result with good range of motion, less pain, fair amount of longevity. Those were the designs which were naturally selected. From that emerged the second generation. And that is where they started merging the two ideas, functional and anatomic. TKR became more acceptable and reliable. This is when the kinematic and the surgical principles used today emerged, and they still remain today as they are. In the third generation, 1990s onwards to 2000, they were further improving the second generation designs. Longevity improved. There was an introduction of minimally invasive surgery, navigation, and high flexion designs. And the fourth generation can be defined as a quest for perfection. What are the areas that we wanted to perfect? Further improve on function, decrease wear, and decrease the need for rehab. We want, or the holy grail is 100% forgotten joint for all our patients. Diving deeper into the first generation, this was the first metal and plastic knee. So as you can see, there is an all poly tibia and a thin rim of metal, which were used on both sides. So here you can see what an anatomic design was like. They have tried to preserve as much of the anatomy as possible, create a design which was in the least conflict with the anatomy. In 1969, Iftikhar came up with the first metal bed tibial component with a modular polyethylene. 1970, the Freeman-Swanson knee. First square cuts on the bone, cruciate resection, and gap balancing. So as you can see, these principles have lasted more than 50 years and they hold good. It's mind-boggling to imagine that someone way back in 1970s with absolutely no exposure to what a total knee should be like can come up with designs and principles which have lasted over 50 years and will probably last more than a century. 1972, the first anatomic knee was designed. And 1974, that was the total condylar knee, the first post and cam mechanism, as you can see here, came into being. 1974. 1976, the first mobile bearing unicondylar knee. 1977, buccal powers. This is still one of the most popular knees and is being routinely used even today. A testimony to its design and to the foresightedness of the people who designed it. They incorporated a very congruent femur to the poly design, and they allowed the poly to rotate on the tibia, thus separating out flexion extension and rotation at two different levels in the hope of decreasing wear and improving function. In 1978, Peter Walker and Ewald, the first kinemax, the kinematic knee, came into being. IB2, the precursor of most modern designs, began its journey with IB1 in 1979. Thus, the four names who led the changes or the designs in the first generation knee were Freeman, Insole, Walker, and buccal powers. Key features: mobile bearing was introduced in the first generation, instruments introduced for reproducibility, and improvement in fixation. The second generation was the launch of AGC. Among the older generation who have used the AGC, you'll have people who would swear by AGC. They'll say, I would not want any other design other than an AGC. It still forms the gold standard against which survivorship of most modern knees can be measured. It had a monoblock base plate on which the tibia and the poly was molded onto the tibial base plate, company fitted. And it had that classical I-beam keyed. In 1986, the launch of PFC. High contact area, improved sizing, and the biggest change that came with PFC was generation 2 instruments. Very, very accurate instruments. In 1986, again, the same years, discovery of the single radius by Ann Hollister and Kester, and the birth of the single radius design, the first design being Scorpio. 1988, Kinemax was launched. 1991, a single mediolateral radius, a radius from medial to the lateral in the femoral component, allowing for rotation at the bearing surface. And the birth of a delta key. Thus, the key persons who, and of course, you can recognize Dr. Ranawat here, Merrill Ritter, Dr. Ranawat, Scott and Thornhill, Kester. The key features were improved sizing, improved instrumentations, and reproducibility. Key lessons were there was still a challenge with range of motion and constraint. There was backside wear even with modular implants, and there were issues with mid-flexion instability. Then came the third generation. As you can see, we are still in India today using the first generation buccal papas design. AGC retired just a couple of years ago. And amongst the third generation, almost all designs are still available. Next gen was launched in 1994. PFC Sigma, 1996, still going strong. Father of triathlon design, Scorpio, single radius design, 1996. And navigation was born around the same time, with Krakow leading the charge and defining the anatomic landmarks, the methodology for use for navigation. So the third generation defined improved kinematics, navigation, and minimally invasive surgery. But the key challenges still remain. Younger patients still failing, rotational constraints still an issue, and 25% of the revision were still due to wear. if we were to look at the summary of the first three, amongst the key names, you find the major brands which are available. Next Gen, PFC Sigma, Kinemex, Scorpio, AGC, LCS. So the designs we see today were essentially created in the 1970s and 80s. What we are seeing are improvements rather than major design changes. As they say, the more things change, more they remain the same. Let's look at specifically the design features. Cruciate retaining were the first to come in. They had a flatter insert. Both, there was no ACL, PCL was retained, and the rollback mechanism was not built into the design, but was based on the management of soft tissues by the surgeon. The advantages: less bone loss, better proprioception. But the problems were that balancing can be a challenge, and if inadequately balanced, it can lead to early polywear or loosening and decreased range of motion. The next two evolve were the posterior stabilized, where the designs sacrificed the anatomy but allowed for a cam post mechanism with more contact, more posterior contact and extension, more AP translation and flexion. But they also came with their own unique set of problems. There were cam jumps, post wear and post fractures, patellar clunk. Thus, as these two further converged from the CR to the PS, in between came the anterior stabilized. It was a CR insert with a high anterior lip. The PCL could be sacrificed without the post and the cam mechanism. It was more bone preserving, but then still had problems of wear and less rollback. This brought the new design, the medial pivot, which was more congruent medially, less congruent laterally. So the ligament function substituted with articular geometry. The medial pivot in deep flexion allows the lateral condyle to rotate. Then came the dual pivot, the lateral compartment being spherical conformation and extension, whereas in flexion, it becomes loose to allow for rotation. And as you can see, all these designs over a period of time have given a better knee feel for our patients. The other important design feature is the mobile bearing. It's a rotating platform which allows rotation at the lower level and flexion extension between the poly and the femur. Provides both congruity and mobility. Low contact stress, lower constraint force, but then it also had its own unique problem of a bearing spinner. The studies, however, do not show any major difference, neither in survivorship, even at 20 or 25 years, neither in range of motion nor in terms of wear. Then came the semi-constrained knees, wherein, though non-hinged, they had a much larger tibial post and a deeper femoral box, allowing for a far greater constraint. These are the designs that we normally see in revision knees. And of course, then came the constrained knees, which were either the rotating hinges or the simple hinges. A small this thing about how each of them plays out with the anatomy and function. A cruciate retaining wherein ACL is removed but the PCL is intact. Here the articular geometry is the same both medially and laterally. Posterior stabilized, ACL and PCL both are sacrificed. Medial and lateral articular geometry remains the same, but there is a cam and post mechanism which substitutes the PCL function. Anteriorly stabilized, wherein ACL is removed, PCL may or may not be present. The articular geometry remains the same both medially and laterally, but there is an anterior lip which functions to allow a smooth rollback and functions like a posterior cruciate ligament. Medial pivot, here it is necessary to remove the PCL, even though there is no cam and box mechanism, but the articular geometry is different. This is more confirming medially, lax laterally, allowing for rotation as the knee flexes. Dual pivot, wherein it is more confirming laterally in extension, whereas it is more confirming medially in flexion. Semi-constrained with a tall post and a broader box, and constrained in form of hinges. Moving a little bit to implant materials. A lot has changed. Being that it has to be biocompatible, we must be able to duplicate the knee structures that they are intended to replace, strong enough to take weight-bearing loads and stress while bending and straightening, and should be able to move smoothly against each other as required, with giving us a good survivorship. Polyethylene, since its inception in the 1960s, the base has not changed, but its properties with cross-linking and irradiation have changed. Polyethylene with fewer cross-link chains leads to production of wear particles and osteolysis. There is more wear in a less cross-link polyethylene, whereas highly cross-link polyethylenes created by irradiation can decrease wear. The process of cross-linking by irradiation can generate free radicals, and quite often they are treated thermally to prevent or release these radicals. The second generation of highly cross-linked polyethylene is created by multiple levels of irradiation and prevention of oxidation, addition of vitamin E as an antioxidant, is quite commonly seen in all the new polys. What do the data say on polyethylenes? In vitro, definitely there is less wear with highly cross-linked polyethylene. The Australian registry has been able to document way back in 2013 and even the recent ones that the highly cross-linked polyethylene ones have a far lower rate of revision compared to conventional polyethylenes. But then, as always is the case, the British registry probably does not show overall survival benefit. Amongst the metals we have seen are titanium alloys, cobalt chrome, and zirconium, the last to be added. Titanium are biocompatible in nature. They have been used extensively in hip implants and in trays of knee implants. Most femurs, because of lower stress shielding, but higher fracture rates from titanium, will go with cobalt chrome. So at present, the designs that we see, most of them have cobalt chrome as femurs, and tibial trays can be either cobalt chrome or titanium. Ceramicized metals have been in vogue since 2000. They are the fourth generation material for knee implants. They are hypoallergic, and their primary usage is in patients who are known to have allergy to metals. In summary, in 23-24, cobalt chrome is the gold standard for metal components, femoral components. For those allergic to metal, ceramicized metals, or gold as they are commonly referred to as, and then on the poly front, highly cross-linked polyethylene is a choice of poly. With improvements in materials, they have allowed us improvements in designs or allowing more freedom with designs. And that is why what we are seeing, the newer designs that we are seeing today, is moving somewhere between the more confirming posterior stabilized design to the less confirming CR, somewhere in between. And that is where our newer generations of implants and designs are coming from. This is the common table for constraints. Cruciate retaining are the least constrained. A lip CR has a slightly higher constraint. Then comes the posterior stabilized plus or deep dish for mild MCL dysfunction, a rotating hinge in case of an absent medial collateral ligament, and a simple hinge when all collaterals are gone along with weak quadriceps. So if we were to go back to the starting point from where we emerged, two distinct directions, functional and anatomic. With improvement in materials, the design directions now has definitely shifted to the anatomic side. And the newer designs, the newer alignments that we'll be looking at would be definitely more towards lesser conflict with the native tissues and preservation of native tissues. Thank you for your kind attention. We'll be happy to take questions.
So thank you, Manish sir, for a wonderful session,
Thank you,
wonderful
Corona Remedies,
insights.
for giving us the opportunity.
No, the journey of me before my birth to till date, it was completely covered. I don't think no one has got this kind of broad insights on knee, but this one wavelength of a knee from a first knee to today, the journey has shows your passion towards the knee. And definitely in the upcoming session, the doctors will definitely have more insights and more learning for sure. And just before going to conclude the session, we request all delegates to share their questions, if anything, in the comments box. And just to brief you, sir, we have 813 delegates who are watching this program today currently.
Hopefully, uh, we have ensured that we haven't wasted their time.
Absolutely, sir. Absolutely.
Thank you.
We'll wait for a couple of minutes for a questions, if any, so that we will conclude, sir, then.
In the meantime, we would take this opportunity to highlight the fact that uh, one of the new innovations coming in terms of mixed reality for total knee replacements. We are to perform a live surgery at ISHK, and we would take this opportunity to invite everyone to Kolkata ISHK 2024 to witness for the first time a live surgery with mixed reality.
Wow, wow. So the mixed reality concept in India itself is going to be the first time, sir?
Yes, sir. Mixed reality in total knee, probably it will be the first in the world.
Oh my God. Oh my God. Oh my God.
Yes, we hope to showcase that at ISHK, and we have some very experienced surgeons who will be performing the surgery with that technology.
Very nice, sir.
So there's a question. Does robotic play a role in the survivorship or design consideration of the economics? Does it play any major role in survivorship?
Okay, maybe I can answer. Let me repeat the question first. The question is that does robotic uh, play a role in terms of design and survivorship? Any technology be it robotics, be it mixed reality, be it computer navigation alone, be it patient-specific instrumentation, help a surgeon execute a plan in a better manner. The question is, where are you planning to go? Even with robotics, you would need to dial in a plan. And for that plan, it is important to understand the design of the joint that we are putting in. We need to understand the patient anatomy and the desired alignment, which would be confirming with the design features of the joint and the patient's own anatomic features. Thus, robotic technologies or any technology for that matter will definitely improve results. But it's like saying that if I have Google Maps, it'll improve my driving. No, it would not. It would allow you to reach your destination properly. But then, unless your destination is well defined, it will not help. And to understand where you want to go, you need to understand the design of the joint, the materials used, and based on that, what should be your alignment strategies. And then you can use the robot to achieve those goals. So at the end of the day, it is what you plan based on the designs of the implant that you're using, based on the population or the patient population that you're treating, which will define the results. We see a lot of papers wherein there is conflicting results. Like papers which will say that robotics will not lead to improvements, and there are papers which will vouch for the fact that robotics leads to a dramatic improvement. The ones which have improvements are the ones where the surgeons have been able to define their goals properly, wherein the robot or any other technology has been able to reduce the surgeon-led execution errors, not the planning errors. Any technology will help reduce execution errors. Planning has to be done properly. And if that is done, then the technology will help you in executing that plan. The other question that is that the market is dominated by robotics. How do we make the patient understand? With the knee becoming a more common surgery, TKR becoming a more common surgery, commercialization of the procedure is bound to happen. Marketing of the procedure is bound to happen. And at the end of the day, it is the surgeons themselves who have been marketing for a particular brand, a particular design. Let's say people have been marketing for gold knees, people have been marketing for navigation, people have been marketing for patient-specific instrumentation, people have been marketing for robotics. In the long term, the only difference will be that the results of the surgeons who have planned properly will be better. Marketing can help give you an initial jump, but unless your results speak for themselves, at the end of 10 years, 15 years, 20 years, nothing else will matter. It is just you, your patient, and your results. The other question was over time difference between robotic surgeries and 3D technology. I think it's a little premature for this talk. At present, we are primarily focused on history of TKR and different design philosophies. My feeling is that any technology which plans pre-operatively will always save time on table. So any robotics surgeries which plan pre-operatively as a separate plan and then just executed on table will always be a little faster than anything which has to do everything on table. But then having said that, a lot of people with experience can come up with the same time as a conventional one. Does robotics play a role in survivorship or design consideration of the implants? Robotics does not play a role in design considerations of the implants because whenever a design implant is designed, it has not been designed for a particular robot. The implant design is completely independent feature of the implant. Robotics, like I said earlier, will improve on execution errors by the surgeon. Hence, a lot of papers where you read, if there is a single surgeon series, and that too with an experienced surgeon, the results will be equivalent. If you have a mix of surgeons operating from inexperienced to well experienced, but then you have a kind of registry kind of data, probably we would see something towards in favor of technology. But survivorship is not dependent on execution errors alone. We need to remember that. It will depend on what the surgeon has planned for that patient in terms of his alignment goals, in terms of the function that he wants to achieve for that patient. So survivorship is, execution errors forms just one small part which plays a role in survivorship. It's not the only thing. So thank you for the time and thanks for your attention. It has been a pleasure.